been pulled up, suggestive of volume loss and right upper lobe collapse consolidation. That happens quite frequently. It's very important to remember that the azygos lobe looks like that. So when the right upper lobe goes up in collapse, it doesn't go all the way up. If it has gone that much up, this part should be completely opaque. So for the right upper lobe to collapse so much that the fissure has gone the normal fissure has gone all the way up, this would be completely radiopaque. So it would be white. This is clearly a smooth thin line, and this part of the lung clearly has air in it. So this is normal lung and this is normal lung, and the only fissure or line it can be is the azygos line or lobe or fissure, however you describe it. When you have the azygos line or fissure, it is very common to see that fuzziness there. It is only because of the anatomical orientation of the fissure, and it's not pathological. That's not to say that you can't still get consolidation in that part of the lung, and it's very reasonable for somebody to say, oh, I can't exclude superadded consolidation, although that looks like azygos lobe. And over time, you gain the confidence to call it the more you see it. The other most common overcalled pathology.
Stop here. Yeah? A few questions for you.
Okay.
So somebody wants you to give a quick review of the first slide, which we can do in the end. Don't worry about that. So okay. How can we describe landmarks for paraspinal line and azygos line? How can we, I'm repeating the question, how can we describe landmarks for paraspinal line and azygos line?
So that's a very common question people ask. I think there is a comfort people find in absolute values. People want absolute clarity in the exact millimeter diameters. It's not like that in normal life. What is normal? 3 millimeter may be normal for me, but not be normal for Dr. Khan. It depends on your height, your age, your weight, and your general health. So it's very important not to get hung up on the exact centimeter or millimeter that something needs to be from a distance. So if this patient was lying down a bit more or reclining a bit more, this line could move a bit laterally, and that's still normal. In terms of the paraspinal line, there is no definite millimeter or distance that it can be from the vertebra. The important part is to see that you can see the outline of the vertebra. If you can't see the outline of the vertebra and this is as dense as this is clearly soft tissue. In this case, it isn't. You can see this lucency next to it, and you can see lucency on top of it. So it gets lighter when it crosses a vertebra. It gets lighter when it goes lateral to a vertebra, and that's the normal appearance. The exact thickness of the paraspinal line is insignificant. If it's smooth and regular, and if it's even a bit more thicker than this, it's still normal. What is not abnormal is you look for lobulation of it. You want to see it lobulated on both sides, or you want to see it lumpy or curving outside. That's the pathological bit. For the azygoesophageal recess, it is a normal structure. So azygos vein goes up and it drains into the SVC. In a short, big person, the SVC may be lower. You've stuffed a small heart in the chest, so it may go in and it may finish there. In a tall person, the heart or the chest may be longer, so the azygos vein will go higher, and then this is a tall person's X-ray. But it always finishes below where the trachea bifurcates. So this is an easy way to remember it, is the trachea will be bifurcating and the azygos will be going into the SVC. You don't always see it as clearly as this in a normal patient, but then if you see it higher density, or if you see something white here and you think, oh, I can't see the line, is it important? Then what you do is you compare, and that's the best part about chest and organs that have two parts. You can compare the two sides. If it's fuzzy or white hair, it will be fuzzy and white hair and hair. So if it's somebody is big and they have a lot of mediastinal fat, it will get fuzzy on both sides. So there is no absolute value of where the SVC or which vertebral level the SVC and azygos will join. I hope that answers the question.
Yeah, so one more question and then we'll carry on. So this is, why is it named azygoesophageal recess? And second part of the question, what does it do with the esophagus? Another question mark, Can you explain on it? So basically, they are trying to ask you, why do we call it azygoesophageal recess? The esophagus, what is it? Has that thing
Yeah.
to do with this?
Let me go forward and find the CT slide. That will be explained on CT appearance of it. In this one, you can see it a bit. So this is the azygous vein, for example, going in, and this is the esophagus. So zygoesophageal recess is the part of the lung that goes behind it. So recess is an empty space, and the azygous is going and entering into the SVC, and the esophagus is medially. So there is space there, and automatically the lung will expand into that space. So recess means space. If I want to say there is a tumor in the zygoesophageal recess, I'm saying there is a tumor sitting here in the lung. So recess is described on CT, is the space in the lung. The line is that boundary or the interface between the two different things, but it's caused by the same structures. It's a descriptive way of describing where the pathology is.
Okay, thank you very much. I'll not ask more questions. Please carry on.
So coming to the costochondral junctions, again, this is something overcalled very frequently. The costal cartilages calcify later on in life, but depending on your diet and your genetics, it can calcify very early on as well. And by that, I mean late adulthood. In some people, they have an extra joint there. And when you have a joint, you automatically have some thickening of the cartilage on both sides, and that automatically becomes permanent. So very commonly, that junction is very dense, usually denser on the right side. Extra joint is more common on the left side. Either way, this is very commonly overcalled as a nodule in the lung and generates a lot of unnecessary CT. It is easy to explain it or identify it as a normal appearance. But if you are reporting thousands of chest X-ray, there will still be one every now and then that you look at, and then you can't convince yourself that is actually normal. And it is entirely reasonable to have a CT be recommended to clarify things. What is not acceptable is for you to describe it on every other day, because that's how commonly you will see this appearance. You will see it on every 10th or 12th X-ray once you look at it. And now if you go back and notice it, you will see that this junction is very dense in normal people. Again, it's still possible for a tumor to be hiding behind that. So if this was an X-ray in 18-year-old who came with rib pain or cough, you would discount it and call it normal, because 18-year-olds can have prominent costochondral junction joints, extra joints like that. If this was a 45-year-old chain smoker who came with hemoptysis and weight loss, and you looked at that, and you couldn't see that lucency of the joint through it, you think, is it worth taking the risk? Should I just get a CT? And that's completely acceptable as well. Because I don't know if most of you know this, but in the UK, for hemoptysis and certain indicators like age and smoking history, you are warranted to go straight to CT and should be offered that. So there isn't a role of X-ray when identifying lung cancer in somebody who clinically has a high suspicion of cancer. Sorry about that. So this is another one, and this is just to keep you guys awake. I know some of you may be fasting. This is an X-ray just to see if you can tell me if you think this is normal or abnormal, or if it's a normal variant. So I'll give you a couple of minutes to think about it.
So this is open for chat. Yeah, that's fine. If you can, please, over to you.
Okay. So somewhat variable responses there, but a lot of you have picked that this is a normal variant. Some of you have called this as pathological. Again, understandable, and I'll tell you why later on when we come to the silhouette sign. What this is a normal variant. Uh, it is a normal variant, but it can still be symptomatic. It can still cause pathology if it is too extreme. What it is something called pectus excavatum, is the depression of the sternum, and that can be further classified as in regards to where that depression is, the top half or the middle half. It has certain severities in terms of how much that compression and that narrowing of the chest is. How these patients normally present is with a normal abnormal ECG, and that abnormal ECG is because of the abnormal axis of the heart, because it's pushed, so it rotates a bit when it's pushed, and the ECG leads. How we read an ECG is based on the presumption that the heart is sitting a certain way, so that electricity is flowing in a certain way in the heart. When you change the axis of the heart inside the chest, those appearances on an ECG can change and can be interpreted as abnormal. They can also have chest pain, and very extreme cases, they can have breathing problems if they don't have enough space in a growing skeleton to expand the lungs when they breathe in. On chest X-ray, it's either missed or it's called as a middle lobe pathology, because the middle lobe is sitting next to the heart in that place. Most people interpret it, when they call it pathology, they will say fuzzing of the right heart border suggestive of middle lobe consolidation. And the patient will have antibiotics and come back in 6 weeks and still look like that. And somebody will say persistent consolidation, more antibiotics, and they will come back. So this is the normal variant, which is caused by the depression of the chest. What that depression has done is push the heart to the left side, and that the normal heart has at least 1/3 on the right side. This is pushed into the left, and that place is now occupied by the right middle lobe. And the other thing to consider on the lateral view, while we have it on, is on a lateral view, the lung gets more loosened as it goes down. So that's the most important thing to remember about the lung appearance on a lateral view. Is you shouldn't call these vertebra abnormal. You shouldn't call this consolidation on the top. A normal lung is thicker or bigger as we go lower down. There is more air in it. There is more space for the X-ray to go through. So a normal lung always gets darker as you go down in a lateral view. Again, lateral views are getting more and more obsolete. The purpose of a lateral view was to clarify findings on the frontal view, to help identify or specify where the pathology is. Conventionally, they have been used to delineate hilar structures. So if you saw something on a hilum there and you couldn't figure out if it was a vessel or if those lumps were nodes, on a lateral view, you could see those nodes as end-on nodules. So that's something it was used on historically. But now if you see suspected hilar or mediastinal lymphadenopathy, 100% of us will go to CT. And that is absolutely the right thing to do. With the lower doses and the ease of access to CT across the world. The other thing lateral view was conventionally done for was to assess the vertebral column in a chest. We still do lateral views, but those are almost entirely for MSK now, because you're looking at the bones and not the lung or the heart on a lateral view anymore. You will occasionally be asked to give an opinion if you are a chest radiologist or a body radiologist, to give an opinion on a lateral view, because an MSK radiologist was reporting the spine and they saw something. And 90% of those abnormalities will be normal structures because of projection. That's just a slide I've put in to show the anatomy of the diaphragm. And I just put it there to put it into context, because when I describe diaphragm to registrars, people don't appreciate the bulk and the sheer size and the musculature of it. For those of you who may have been involved with lung intervention, you do know how exquisitely painful it is if a needle touches a diaphragm. So even for a lung biopsy or underneath a liver biopsy, any needle, any any wire, if it touches or crosses the diaphragm, is the patient will jump off the bed and hit the roof. That's how thick, how muscular, how innervated a diaphragm is. And that slide is just to put it into context that you should think of the diaphragm as a whole organ. It is something that is holding your chest up and separating the two structures. It is very strong musculature that moves with every breath. It is important to remember that in strong athletic people, or people who are genetically gifted with strong musculature, and in certain ethnicities, the muscular insertion of the diaphragm can almost look like pathology. If you look at bodybuilders, or if you look like more commonly the more mixed martial arts people, the MMA fighters, because of how they exercise, their abdominal muscles and the pressure generated, and their diaphragm gets so strong that if you image them in a cross-sectional way, the insertion of the diaphragm almost looks like a rope on each side again and again. That's how strong the diaphragm is. So, and because it's such a big organ, it is important that although pathology primarily originating from the diaphragm is rare, but when it does originate, it is very significant. So it can be, most people only think, oh, what can happen to a diaphragm? The max it will do is get paralyzed, because friend, that's the the MCQ scenario, isn't it? The phrenic nerve palsy, elevated diaphragm, and that's about it. What we don't realize is it's a muscle. It's a muscle, so it's prone to the same tumors that any other muscle is. When it does get primary diaphragmatic tumors, they are very, very aggressive. So it's very important not to miss them. If you miss them and the patient comes back in 6 months' time, they have gone to stage 4. So that's just for you to guys to respect the diaphragm a bit more. And this is just another slide to tell you about the lateral view. We went through the lateral appearance of it, that the lung gets more loosened as it goes down. The other thing to remember is that there are two diaphragms. So on the lateral view, don't consider that as an artifact. The right and the left diaphragm don't sit superimposed on each other. They're slightly off, so you will see both of them separately. The easy way to remember is the heart is sitting on the left side. So the left diaphragm at some point is touching the heart, and they're both muscles, so you can't really tell them apart. Whereas the right should be visible all the way through. There is some literature saying, oh, the right must be this much higher than the left on the lateral view. It doesn't matter. It doesn't matter. It can vary for 100 reasons, and at the end, it doesn't matter. As long as it is smooth and the patient is asymptomatic, don't go ahead and overcall things you see. The most important thing on a chest X-ray approaching lateral or frontal view is, I see something. Can I explain it away? And what I mean is, when I see something, can it be something that is normal? So the minute a registrar says, oh, that's a nodule, I say, what else can it be? Can it be something in front of the nodule? I mean, in front of the lung, behind the lung, next to the lung? Try to explain it away. And when you can't explain it any other way is when you come to the conclusion that this is pathological. Because unfortunately, as time goes on, we are less and less interested in chest X-rays, and unfortunately, that's a route to over requesting cross-sectional imaging. So it's a vicious cycle we are in. A lot of pathology that we pick on chest X-ray is actually normal variation of a normal person. So in terms of doing that, when you go to an exam setting or a course setting, it suddenly becomes very hard to report a simple X-ray. And the only reason that is because you don't have previous films. When you report on your trust computer or your hospital system, you have access to patients' whole life behind you in most places. And now the packs are going back to 2 decades at least. So the most important film in any patient's history is the previous film, not the current film, it's the previous film. So the minute you open an X-ray and you think, oh my, that's abnormal, you open the previous and it's there, or slightly different, or almost different, no different. You've reported that X-ray in 10 seconds. If that previous is more than a year ago, that's even better. So your friend, your best friend when reporting a chest X-ray is the previous film. And that will, the minute you try to approach it with that view, you will realize what a huge variation of normal appearances is a human body. Just like a human body can look a million different ways in a normal person, an X-ray is just representation of the same patient. It's it's important to realize that a chest X-ray is closer to it's more dependent on the body habitus than a CT, because a CT is a cross-sectional view. So you're only looking at the organ. The skin and the superimposed tissues become irrelevant. On a chest X-ray, all that surrounds that organ is very, very important because it's on top of that organ for you to see. In terms of the silhouette sign, something we use the most commonly in order to describe a chest X-ray in an exam. In real life, I would recommend we don't use that terminology when you describe it. So when you're reporting a GP or orthopedic X-ray, orthopedic referral X-ray, or a rheumatologist chest X-ray, and you're describing it as the silhouette sign is positive, the referrer doesn't know what you're talking about. There's no point in overcomplicating the report. You need to describe it, but you have to keep in mind who you're talking to, and who you're talking to is the referrer. So the silhouette sign is for you, not the referrer, and it's certainly for the examiner. So the examiner will quiz you about the silhouette sign. You can show off all you want about how you understand the silhouette sign. You use it very commonly when reporting it, but you use it in your head. You don't put it on a report. But it's very, very confusing for the referrer. And I frequently notice that when somebody new has just started their ST1 or 2 block and they just started reporting chest X-rays, they will use all this fancy terminology that they're learning. And part of that reason is they're trying to impress the supervisor they're talking to, but they forget that they're actually reporting for a referrer. And that referrer is thinking, what is a silhouette sign? I don't know what they're talking about. I just want to know, is the X-ray normal or abnormal? So silhouette is the shadow of a structure, is the outline of a structure. When you don't see that outline, it's called the silhouette sign. It's as simple as that. What it helps us do is just identify where the pathology is. That is all it's for. And in chest X-ray interpretation, that is the most important thing you will do. Where is it? Is there an abnormality, and where is it? And it all goes downhill if you can't get those two things right. So, like I said, focus on the silhouette sign, but don't talk about it in your everyday report. But it helps you identify where the pathology is. I've put in some Viva slides, and we'll go one by one, just to reinforce that knowledge. So when you see is an abnormality on these films, I want you to tell me, is the silhouette sign positive or negative? And if it's positive, where is the pathology? And hopefully, what is the pathology? But that's the last part is not mandatory because we're not talking about pathology yet. Today, we're just going to focus on what is normal and what is abnormal.
So we'll keep the chat open for 45 seconds. Anybody who wants to answer, that is your window. That's fine. Over to you, Samavir. You are muted actually.
Sorry, just talking to myself there. Yes, everyone's absolutely right.
The slide has moved. Can you go back?
It's the same slide. It's the answer to the slide.
Yeah. Okay, that's fine.
So that's the first slide I showed you. And the question was, is there an abnormality? Yes. Is there pathology? Yes. Is the silhouette sign positive? Yes, because you can't see the silhouette of the left side of the heart. And the lower border of the left side of the heart is made by the left ventricle, and the top heart is the left atrium. What is sitting next to the left side of the heart is where the pathology is. And that's the lingula. And how we used to confirm it in the old times is do a lateral view. And on the lateral view, you can see the fissure, and you can see that the consolidation is on the top of the fissure. And if you remember your anatomy a bit, here the lingula is on the top and the lower lobe is on the bottom of the fissure. So that is indeed lingular consolidation. with the positive silhouette sign on a frontal chest radiograph. That's your second one.
Okay, so this is open for 30 seconds now. Okay, that's it.
Okay. So yeah, the silhouette sign here is negative because the silhouette of the left heart is visible, the silhouette of the diaphragm is visible. So none of the silhouettes have been lost. So that's a negative silhouette sign. But you can appreciate there is some density here that isn't visible on this side. So you are suspecting there is pathology here. It is not possible for the pathology to be this advanced in the lingula and not touch the heart. So if you see it on the next one, that is below the fissure. So that's in the left lower lobe. So that's a negative silhouette sign with the left lower lobe consolidation. That's the next one.
So again, you've got, for this, you've got 1 minute. So take your time, 1 minute. And Samavia, there is a small red line. You know, if you can, you can clear this. Yes. Still 15 seconds to go. We stop there. Over to you, please.
Yeah, so absolutely right. Iram Afreen Abbasi, absolutely. That was the point to take home on this one, that I told you that the lung will get more loosened as you go down on a lateral view. But here the lung is actually getting whiter as you're going down. So there's clearly something wrong with the lung. The silhouette sign in this case about the diaphragm is negative. I think some of you have called it as a positive sign, maybe because of the heart or the descending aorta. I'm not sure, but this is actually normal appearance. You can get this in a normal heart as well. So other than the increased density of the lung or the superimposed lung on the vertebra, there is no other abnormality on the film. So it's a negative silhouette sign with positive pathology in the left lower lobe consolidation. Right lobe. I think I've put in two different films. Ignore that. Yeah, that's two different films. Mess up on my part. Coming on, does anybody have any questions of the last few films, or should we move on to the next bit?
So any questions? We'll just give them 1 minute if there are any questions. Okay, so can you comment on the silhouette sign on the lateral view only?
So on the lateral view, we don't use the terminology of the silhouette sign. What we're looking on a lateral view is the density, and nobody's going to get the lateral view as their first film. So you either have already picked the abnormality on the frontal film and have asked for the lateral as a clarification, or the lateral was done for some other reason. So I wouldn't advise you to use a terminology of a silhouette sign on the lateral view. I threw that in as to shake things up for you to remember that the lung gets denser does not get denser as you go down, it gets more loosened. It wasn't for to remember to use a silhouette sign on the lateral view. The only silhouette sign that will be very clear is when something is sitting on the diaphragm. And that if you see something sitting on the diaphragm on a lateral view, you most definitely will see it on the frontal view. So nobody does the lateral view to delineate the diaphragm anymore, at least. What we do to remove, identify pathology of function of the diaphragm was used to be and still is in most places is the ultrasound for diaphragm motion. Some places do MRI diaphragm to see it moving. If you want to see the cause of the diaphragm malfunction, you do CT.
Uh, Samavia, I think all the questions point to one thing. If you can go to a lateral view of your choice and just highlight the landmarks of anatomy, and there are questions about how to place something in, if it is in left lower lobe, right lower lobe, where is the right diaphragm versus the left diaphragm. So over to
Okay.
you. Just point out the normal anatomy.
So on a lateral view, the likelihood of you being able to identify if it's in the right lung or the left lung is close to nil. So there is no realistic way you can identify where the abnormality is, right or left lung on a lateral view. What you can do is find out whether it's in the lung or the mediastinum. So the lateral view is about the lateral view of the chest. So to see whether it's anterior, middle, posterior, or the diaphragm, or the vertebral column or the diaphragm. In terms of the outline of the lateral view, in a normal, young, reasonably thin patient, you will see something like this. The right hemidiaphragm you will see all the way through. The right hemidiaphragm is usually higher than the right, but that rule applies to the frontal view rather than the lateral view. On the lateral view, it can be the other way around and it's still not abnormal. It depends on which side you took the X-ray from, whether it was right to left or left to right. The left diaphragm is because the heart is sitting on the front, you won't be able to see it all the way through. Posteriorly, you should be able to see that triangle where the diaphragm meets the back. So that clearly is where a little bit of fluid will sit. So fluid needs to be about 100 to 150 ml in the pleural space to be visible on the frontal view, whereas on a lateral view, it can show up much sooner. So on a frontal view, this may look like a very sharp CP angle, but on a lateral view, you will be able to see a bit of meniscus there and be able to identify pleural fluid. In terms of landmarks, um, unfortunately, you cannot tell whether, if that was the only view you had, you won't be able to tell whether that's L12, T12, or L1 or T11. You have to see the whole spine to be able to reasonably count accurately which vertebra it is. On the lateral view of the vertebra in the chest, you can't identify or differentiate a lower thoracic from upper lumbar vertebra, and it doesn't really matter anyway. In terms of, I'll just move to see if I can move. Yeah, I can. In terms of the vascular structures, like I said, in a thin patient, you should be able to see the aorta, but you can almost lose it beyond the arch, and that is normal. So you don't, what you imagine, thinking about it in a schematic way or in a diagram sort of way, is you expect the aorta to be seen all the way down. You don't see it. So ascending aorta, in most patients, you can see it. If you can't see it, it's still okay. The arch of the aorta is more commonly seen. It's sometimes clear, sometimes not that clear. It's still okay. It's on a lateral view. Historically, there have been, if you look up the literature, somebody will have written a paper somewhere saying, oh, this hilum is higher than the other on the lateral view, and this is the right and this is the left. That doesn't play into much effect anymore. So I wouldn't focus too much on the landmarks on the lateral view. It is what is normal and abnormal. So the lateral view is, if you see lymphadenopathy on a lateral view, I don't think I've put in a film, is you will see it as bang on little balls, because on the frontal view, they are covered with the heart and the other mediastinal outline. So you kind of have to make them out. On the lateral view, you are seeing them end face. So they're much more clear on the lateral view. And it's very easy to be able to differentiate them from vessels on a lateral view compared to a frontal view. There are no other accurate landmarks that I can think of that are relevant to you at this stage for the lateral view.
So you can go back to wherever you were.
Yeah. So the next point I was going to come to was the hidden
And
areas of the chest.
Samovia will give a break after 5 minutes. So last 5 minutes before the break.
Okay. So in these 5 minutes, I'll go through where the hidden areas are, and when we come back, we can see if you can find some pathology in these hidden areas. So the hidden areas is where all of us in our lifetime will at least once miss pathology. And that's the important thing to remember, that it happens to everyone because it is a very quickly reported imaging technique. There is a large bulk of it coming through all of our departments, and the likelihood of finding pathology on a chest x-ray is relatively low, especially these days because you get chest x-ray for a million other reasons, pre-op, post-op, rheumatology, before starting certain medication. So most of us are going through our reporting pile, assuming it's going to be normal, and that's how you get into the speed of it. And unfortunately, that's how we miss things. But the thing to remember in chest, and that's what something that puts off most people from cardiothoracic, is the cost of missing something is very, very high. So in these hidden areas, if you miss pathology, and by the time the pathology is actually identifiable easily, that patient would have gone 3 stages higher in their malignancy. And that's most commonly in the APCs. So both lung APCs should be nice and clean. We all know in real life they don't look like that. Most of the older generation has some sort of post-inflammatory thickening, some fat, some scarring, a bit of emphysema that has had infection and that has healed. So most APCs are not pretty looking, for the lack of a better word. And that is where I almost usually describe this to registrars as they go through a phase of, in the beginning, they don't even notice that area is there. Second phase, they are so aware of it, they over describe it in every single x-ray. The third phase, they're getting more confident, they start under calling it. And when you're a consultant or a senior registrar, by that time you would have missed one patient who came back with a pancreas tumor, and then the cycle starts again. And we all go through it, and it's not an, a pleasant part of our life, but it's almost an inevitable part of all of our lives. Is we will, because of the sheer amount of work we do with imaging, we will sometimes miss pathology. So we can only try our best. The hidden areas I would recommend for review, and when I mean review is once you've reported a chest x-ray, right before you click that verify, you come back and you have a system in your mind. So the first system I told you was inside out. You approach the chest x-ray, look in the middle, go all the way out, all the way to the top, all the way to the bottom. You report your pathology, and right before you click verify, you come back and you say, have I reviewed the hidden areas? The hidden areas are right at the top, right at the bottom, right at the back, and right in the middle. And they are the extremes of all those places. And that's where the most significant pathology will sit that will kill the patient if you miss it. It won't kill them today or tomorrow, because the pathology that kills you today on a chest x-ray is very, very visible. The pathology that kills you 2 or 3 years from today is what you will miss. The incidence of lung cancer, unfortunately, is very, very high everywhere in the world. In the UK is extremely high. It's the busiest MDTs and most trusts, if not one of the busiest, if not the most busiest and heaviest MDTs. The APCs are abnormal looking in most normal people. What the thing to remember there is symmetry is your friend. A chest has two lungs. So look at one apex. If it looks abnormal, look at the other one. Try to convince yourself that you can say that they're almost the same. If one is thicker than the other, think, is the density high enough for it to be soft tissue? If the density is a little bit high and you have a previous imaging, like I said, the best friend for somebody reporting a chest x-ray is the previous film. Look back 6 months ago, a year ago, it looked almost the same, or a year ago there was infection there and they have evolved into that. You can discount it, but it's important to describe it. And what it does is not does it only give you peace of mind, but if there is an incidence where it actually did turn out to be something significant or a tumor, you can go back and defend yourself and say, well, I did notice it, I did compare it, and this is what I thought. That is completely acceptable because that was your interpretation at that time. It is very easy for us to look back in retrospect and pick faults with us ourselves or other people and say, well, looking back now, you could clearly see it. Well, of course you could see it, you know what it is now. But the question to ask at the point of any discrepancy or any miss is, at that point, was I justified calling it what I called it? So if you have reviewed it, if you have described it, and if you have compared it with the previous film, you are protected. You can defend it to yourselves, and hopefully it won't come to that, but maybe even with very few of us in a court of law. So that's the first and the most important. A little nodule sitting there, clearly asymmetrical thickening of the pleural apex there. Think, is there a Pancoast tumor there? Every now and then, the history will be very good. They will say ipsilateral Horner syndrome, or ipsilateral facial droop, or right arm weakness, or neurological symptoms on the right, or hemoptysis. But real life isn't that kind, is it? So you're not going to get a very accurate history because a junior doctor somewhere has filled out a request the consultant asked him to fill out. So the request will be like something along the line of pathology question mark, or normal question mark. We get all sorts of simple requests these days, don't we? So apex first and the most important one. The second, and probably the least known one about, is the fact that the lungs are bigger than they look. So the what you see as the outline of the lung at the bottom is actually not the lung, it's the diaphragm. It's a thick muscle sitting there. What most people forget is there is lung in front of it and there is lung behind it. So the diaphragm is going up, there is lung above, in front and behind it on both sides. So just because almost all of us in our speed in the beginning can perceive that, oh, the lung's finished, not realize that there is lung there, and the lower lobe is lower, the posterior part of the lung is lower than the front part. So there is lung behind the diaphragm on both sides. On the very rare occasion, you will see high density lesions there. And then the question will be, is it in the lung or is it in the liver? But it's important to review that area. On the left, what most of us are looking for is air under diaphragm. That's the conventional and the go-to question, isn't it? Have I looked for air under diaphragm? But it's not all about air. It's about soft tissue as well. We have to remember there is normal left lower lobe sitting behind that diaphragm. You were looking at the gastric bubble. You're looking at maybe a colon going all the way, or the spleen, but you always have to keep it in the back of the mind that the lung is there as well. The other hidden area is behind the heart. Again, in a under projected, not sitting up straight patient, it can look denser, but in a normal sitting up patient, it can be very easy to pick a retrocardiac opacity. The retrocardiac opacity is, if you have picked it, it's very easy to describe it, and it's a very limited differential anyway, because 99 out of 100 times it's going to be in the left lower lobe or the lung. The other thing, I think this isn't so much as a hidden area because we do know to look for it, we do review it routinely, is the hilum. What happens with hilum is it's a hidden area in the sense that when we think we have picked something, we don't try to describe it away. And this comes back to the first principle, one of the first principles I told you about, is when you see something, say, can I describe it away? In very nicely projected, good quality radiographs, the pulmonary arteries can look very prominent, and very commonly these are reported as bilateral hilar lymphadenopathy, or my favorite is cannot be ruled out. Well, of course it can't, nothing can be ruled out, but the lumpiness or the lobulated contours of the pulmonary artery can look like lymphadenopathy to a junior radiologist. And so when you think there is lymphadenopathy, think to yourself, can I describe it away? Whatever lump you see, can you follow it down? Does it continue downwards into a linear structure? So can it be a pulmonary artery? Can it continue upwards in a linear way? So can it be a pulmonary artery branch to the upper lobe? So, and most of the time you can describe it, you can go and look at it again and see that it does extend into a linear structure, and that means that it's actually a pulmonary artery. So hidden areas again, the APC is the lungs, at the bottom of the chest, behind the heart, and the hilum. This is undercalled, this is undercalled, and this is usually overcalled. I'll take a break here. Is that okay, Dr. Khan? It's 7:11.
Yeah,
Should we come back at
take a
7:16?
yeah, that's fine. We'll take a 5 minute break.
Okay.
So if you can unshare your screen, please. Samavia, before you begin, in current era, do you do apical view? Somebody is asking if you find it useful. Do you do it? Over to you.
Absolutely not. I think we need to move away. Most of us have moved away. CT has clearly superseded any other view you can do on a chest X-ray. The apical view, the decubitus view, the lateral view, all those fancy things we have learned very painfully in our training have now gotten very obsolete. And part of the reason is chest CT is now so low dose. There are low dose CTs, there are ultra low dose CTs. There's barely more than 7 X-rays, isn't it? So there is no point. It's not worth the hassle, or there's still, although smaller, but there is still a risk of missing pathology on plain radiograph. So no.
So please continue. Please continue.
Okay. So I think this is the next slide from that hidden area one. This is just clearly showing the lung, the lower lobes extending behind the diaphragms, and the need to identify that. I have a few Viva slides after this, and we'll try to get through them quickly so we can move on to the next section. Okay. Killed the surprise.
So this is open for 1 minute, please. Chat is open and you can participate in this.
Okay, I think you're all absolutely right. And I did kind of kill the surprise by moving on. I was trying to mute myself before my 6-year-old walked in singing. Instead of muting, I moved the slide forward. So yes, indeed, there is a high density behind or inferior to the right contour of the diaphragm. And that, like I said before, could be in the liver or the lung, but because it's higher up and slightly ill-defined, for it to show up in the liver, it would have to be significantly higher in density than the liver, and the only thing that can do that is something that is calcified. So yes, that is indeed right lower lobe lesion showing up there, and that clearly shows you how subtle the abnormality is on plain film and how big the tumor is on CT. This is the second one, again review for the hidden areas.
So open for next 45 seconds. Last 10 seconds, please. Over to you, please.
Okay. All of you are absolutely right. There is something behind the heart on the left. What I would say is be cautious using the word mass on a chest X-ray, because when you use the word mass, you are actually saying cancer, and that's what the referral will tell the patient. That they will have a very difficult conversation with the patient if that happens to be not cancer, even though that's good news. That's unnecessary stress. So really try to move away from committing to mass unless it is very clearly a mass. In this case, it's not. It's something behind the heart. There is no clear boundary to it or margin to it or lobulation to it. So yes, it's behind the heart. Yes, it's pathological. Yes, it's in the lower lobe. But is it a mass? You can't say that on here. And this one, I don't think is actually a mass. Um, that's the next. I don't have the CT for it, but yeah, this is left lower lobe consolidation. This one is the third one.
Open for 45 seconds. Last 15 seconds, please. Over to you, please.
Okay, so this was for review of hidden areas again. And the hidden areas we talked about were the APC, the bottom, the top, the behind, and the hilum. So the bottom looks okay. Some of you have mentioned this. This is the diaphragm. You can clearly see this is a structure all the way through, so it's not a defect in the diaphragm. This is a gas filled structure, so it has to be the bowel. There is no free air, so it is a normal structure. Whether that's too dilated or whether it's a normal variant, some have called it utilities. That's not what the film was for. The film was for reviewing the top half. The APCs are clean. You can see all the way air all the way to the top. This bit I told you is usually normal, but what I told you was symmetry is your best friend. Old films are your best friends. So on this one, you have to look closely at the other side. So the likelihood of costochondral junctions being this asymmetrical is a bit unusual. So you would think, is this actually a costochondral junction, or if I magnify it, the rib goes like that, and then it's this nodular appearance. So this is indeed a left upper lobe tumor hiding behind the costochondral junction. This is the last one.
So open for 45 seconds, please. Last 15 seconds. Over to you, please.
Yeah, just looking if there's a magnify button. So yes, this indeed had a few areas that some of you have called pathological that are not. In terms of the costochondral junction, this again is prominent here, but immediately you would compare to the other side, and this is fairly comparable. So this is prominent, but this is almost similar on both sides. This is normal appearance. Some of you have called this as a lesion. Some of you have called it a paratracheal stripe. So I think what you're trying to say is abnormal or thickened paratracheal stripe. When we were talking about the paratracheal stripe, I did say that that is actually the paratracheal stripe. When you want it thickened, you wanted this soft tissue density. What you are seeing here, I think some of you are getting confused with this haziness here, and some of you people who routinely report chest X-rays would see how common this is. Uh, and the way to differentiate that is If you think this is a paratracheal stripe, then what is this? This actually is a paratracheal stripe, and this is 2 to 3 millimeter with a normal image. Is there any nodularity to it? Is there any bulkiness to it? And the answer is no. There is something lateral to it, and this lateral structure goes all the way down, and then it turns and enters the heart. All the way up, it goes lateral. So what could that be? That's the SVC. That's the normal venous structures. And most people, when they lie down, for older people, it gets a bit engorged and it looks prominent like that. Or you have a bit of thyroid that look a goiter that looks like that. This is normal appearance. But yeah, it's good that you appreciated it, and over time you will notice how common this is. I noted when we were on the break that some of you had chat on the chat put a comment saying, how can we be sure that the opacity in the lungs is not pleural thickening? The answer is you can't be sure. It's just practice over time. The more you report, the more you learn, the more confident you get. But there is still a chance. Some of us will miss. There's only so much we can pick on imaging. The take home message would be, try not to undercall, appreciate an abnormality, try to explain it as normal. If you clearly can't or it still makes you uncomfortable, go ahead and be safe and either get an expert opinion or request cross-sectional imaging if a more expert opinion is not available. So certainly be safe. But if you adopt the cross-sectional imaging every time you see a bit of pleural thickening, you'll be doing that all day. Um, think that was the last of it. So next we will do mediastinal anatomy. In the mediastinal anatomy, it will be a very basic sort of approach, and it is only to help you understand how to identify the abnormality. Is there one? Which part of the mediastinum it is in? And if it's in a certain compartment of the mediastinum, what could it be? Again, in real life, it is less important as compared to the exam. Most of us don't think about anterior middle posterior mediastinum when we're reporting, and then 2 months before the exam, that's all your nightmares come around that. So the mediastinal anatomy is what we will go through. We will look at it on X-ray as well as CT. I won't go into the heart anatomy and the pericardial anatomy because we have a separate module for cardiac anatomy, and I don't want to confuse you too much and make it too complex for people who are junior registrars. And the whole aim of the session is to have found basics. So if you're ST1 and you can't explain complex cardiac anatomy, normal variants, that's okay. But what is not okay is for you not to know where the mediastinal compartments are and what sits in what compartment. Uh, this comes back to the other X-ray bit we were talking about. So this is a diagram to help you appreciate that this is what we were seeing on that X-ray. When some of you had said on the right apex there is a mass, it wasn't a mass, it was these structures, and because the patient was either big or in heart failure or lying down, this was a bit engorged, and this would extend down and turn into the SVC. The way to identify that is as you go lower down, it gets loosened and you can clearly follow it right into the heart. The structures on the top are called thoracic inlet structures. The most hidden kind of tumors sit there, but not the good thing, but the way those tumors present is very symptomatically, so it's easy to identify them. When somebody presents with symptoms of those thoracic inlet tumors, they're almost always neurological, and they always come from non-respiratory referrals. So all the Pankos tumors or the thoracic inlet tumors I will report would be referred from neurology, orthopedics, stroke physician, things like that, because they have presented with arm symptoms, CNS symptoms, muscle, because that's the plexus sitting behind it getting involved, and that's how they present. Um, on the very rare occasion, they can present with supraclavicular nodes that you can palpate, but that is less common than the neurological symptoms. When there is an opacity that you see in that part of the lung on frontal projection, the thing to consider is what is the normal anatomy of that region, and it's artery, vein, a bit of fat, and a bit of lung. That's all it is. So can you look into the previous records, previous imaging, and see something that happened there that could explain it? Is the patient old? Have they had TB? Have they had a previous infection? Do they have occupational lung disease? All of those would make the lung and the pleura in that part thickened. because when we have inhalational exposures, when we inhale any irritant in the air, that's more pertinent in the third world countries, is there's so much pollution and exhaust and occupational, the industries aren't held to the same safety standards for their workers that they are in the Western world. The workers inhale everything, and when you inhale organic or inorganic irritant, it rises up into the top of the lung. So all the occupational lung disease will happen at the top half of the lung, and all the scarring will happen at the right at the top. What happens is lung compensates for pathology by reducing blood supply. So if there's a part of the lung that is either consolidated or died or died infarcted being the same thing, or fibrosed, any reason a lung isn't performing, the artery or the vasculature of the lung will think, well, I better not give it any blood supply, then there's no point. So the vasculature, the blood supply over time also reduces. So the lung compensates like that. That's why it heals that area off by ignoring it. And that's technically a sterile area, but it's still a risk for future metaplasia or malignancy or infection, because it's a dead, non-functional tissue sitting there. So that's the thoracic inlet imaging. Mediastinal division wise, the only thing you need to remember is one thing: is T4-5. That's the only landmark. That's the only landmark differentiating the superior from the middle and the lower mediastinal compartments, is the T4-5 junction. Do we sit on a CT and look for that junction? We do not. Like I said, this is all. I'm hoping that you will take away more towards your day-to-day radiology practice and long-term practice, rather than focus on the exam only. So I will tell you, for the exam, you need to when if an examiner asks you, is this in the superior mediastinum? Well, you can't sit in an exam and start counting the vertebra. You will verbalize, well, I would count and look at the T4-5 junction. If this lesion lies above that, it would seem to lie in the superior mediastinum. In real life, you don't need to describe that, because in real life, the pathologies are mixed. If they are in the superior mediastinum, they are either extending into the neck, or they're extending into the posterior mediastinum or the anterior mediastinum. In real life, the pathology is mixed. And at that point, it's not about defining where it is, it's about defining where it came from. So you would look at where the bulk of it is, and just roughly eyeballing it and understanding where it seems to come out from or expand from is likely where it originated from. So if the bulk is sitting here and it's extending there and extending there, I would think, what is pathological? What is a normal structure in the superior mediastinum? And what is the pathology that can arise from it? And that's basically the whole point of differentiating the compartments, is for you to understand pathology, because the pathologies are distinctly different. Again, on CT, some people ask, oh, is the aorta in the superior mediastinum or the middle mediastinum? Well, it depends on how tall you are. If you're tall and your aorta, or you're reasonably tall and your aorta goes higher than T4-5, it's in the superior mediastinum. If you happen to be really short, or your heart is slightly smaller than your thoracic cavity, it may be lower. So it doesn't really matter. The junction is the vertebral junction, not where the aorta is. So if there is a lesion here, can it be from the aorta? Yes, but is it in the superior mediastinum or the middle mediastinum is a different ball game. The interior mediastinum is the easiest, because we have all sorts of mnemonics about what it can be and what it's the 40s and all that. But there are very specific normal structures in each mediastinum. Sorry about that. So that's the lateral division of the mediastinum. You can roughly do that division on a frontal radiograph as well. I'll go back to this. You can do that division on a frontal radiograph as well. Can you accurately count down to T4 on a frontal radiograph? You can more easily on than the lateral, because you can see the first rib. You follow the first rib all the way back. That's T1. Go lower down and make that distinction like that. So this would be the first rib going. So this must be T1, 2, 3, 4. and that's a T4-5 junction. Laterally, that's a rough depiction of the compartments. On the frontal radiograph, you can't differentiate between anterior, middle, and posterior based on the frontal radiograph. On the frontal radiograph, what comes into play are the silhouette signs and the hilum overlay signs, and I'll go over them when I talk about pathology. So today we are not talking about pathological signs. We're only focusing on the normal anatomy and the terminology. So don't be put off that I didn't go over the hilum overlay and the all of that. We'll come to that when we go through those specific pathologies. This is the same image on a CT, coronal and sagittal, showing you the superior and the inferior mediastinum and the three compartments on the lateral view. This is just to put into perspective the aortic knuckle. Most people over time think the aorta goes like that. We start thinking in two-dimensional when we are reporting a chest radiograph. You always have to imagine that the body is a three-dimensional structure that you are looking at in a two-dimensional way on a frontal radiograph. So the aortic knuckle is the highest point, or the most, and happens to be the most posterior point of the thoracic arch, aortic arch. And what you that bump is what you see on the frontal radiograph. Some of you, I think one of you had put on the chat, or could you explain the hilar anatomy in more detail? I can do that in the pathological sessions as well. But the thing you are most commonly asked for in exam setting and rarely ever think about in real life is that the right hilum is different in height to the left hilum. If the two hilum are different in height, you won't notice it. The only time you will notice that difference is when there is something distal to that lung. If there is increased opacification and you are talking about or thinking about fibrosis, then you look at the hilum and think, is it too different? Is it too asymmetrical? You don't just look at the hilum and think, oh, one is too much higher than the left. Is it pathological? How can it be if the lung around it is normal? Does it matter? No. The anatomical reason for the difference in height or the slightly different appearance on CT is that the right main bronchus is on top of the pulmonary artery, whereas on the left it's behind it. It's something that is very important to a surgeon or somebody doing endobronchial procedures. It's not that important to a radiologist because you're not looking at the location of that structure. If the right bronchus is higher than the artery, does it matter to you on CT? It doesn't, because you can see what's around it. If what is around it and what is in the wall of it is normal, it doesn't matter if it's on the top or the bottom or the left or the right, because there is all sorts of normal variation in the human body. In terms of the trachea, again, a huge variation depending on your renal function, your diet, your weight, your ethnicity. Some people have very striking calcification of their costal cartilages as well as their tracheal cartilages. It is important to remember, in most cases, it's normal. The one or two pathologies that have excessive cartilage calcification are very, very rare, and the likelihood of you seeing them is low. When they do happen, they present with symptoms and they present pretty late on. So don't always tell the registrars, don't think zebras and unicorns. When you see something, it is likely a horse that is looking like a zebra rather than actually a zebra or a unicorn. So the trachea or the main bronchi, the main airways, the conducting airways of the lung or the chest, are fairly non-variant, as in there isn't much variation in terms of how many main bronchi you have and how many cartilages you have in terms of cricoid or trachea, thyroid cartilage. Apologies, I've been talking all day today. The next bit I get asked very commonly is the dimensions, the absolute centimeter or millimeter sizes of the trachea. Again, huge variation. The only difference in literature or in textbook is in gender. So clearly men's trachea or airways are bigger than the females. but that is assuming an average size man compared to an average size woman. It is entirely possible for a small stature man's airways to be smaller than a tall, broad female's trachea, and that is entirely normal. So don't, like I said, don't focus on the absolutes. The only reason in a viva you will be asked, do you know what is the normal dimension of the trachea, is when you have put the examiner down that route, when you have called it abnormal when it wasn't abnormal, or when you haven't picked that it was abnormal. With time and experience that comes itself, and most of the time the orientation or the shape of the trachea is more important than the size. So when somebody has a big trachea, or you noticed, oh, that, I look, I think it's big, and you measure it and it's slightly, 1 or 2 millimeter over what you have googled on radiopedia is normal. You have to think, why is there pathology to explain it? uh, Most of the time you're not going to notice the trachea. On chest radiograph, the only time realistically you're looking at airways is when you're looking for a foreign body. On the airways on a front radiograph, you don't have size estimates. The size estimates are on CT and MR. So um, don't be put off with the absolute values. Think of the shape of the trachea, and if you think the size is abnormal, look at the reason. Look for a reason. If you can't find a reason, don't call it. The very rare pathological syndromes or causes that cause primary tracheal or bronchial wall dilatation are very, very rare. It is a rare diagnosis that you won't be seeing very commonly. And that's the same view on a coronal CT scan. I've put this slide in because some people still want to know the normal. A rough number to remember is 3 centimeters. If something is clearly over 3 centimeter on an inspiratory CT, you may want to start thinking about, is it abnormal? And most of the time, people want to call it tracheomalacia or something. Tracheomalacia is a common finding, and the older you get, all of our body starts to not function as well as it used to. So the tracheal membrane or the muscle is no different, or the cartilage is no different. What it will do is be less compliant with age. Being dilated is the most common appearance. So the older patients you see on CT, you'll start noticing that the trachea are quite big. If they have managed to take a big breath in or a normal breath in, the trachea looks quite prominent. If they are thin, it looks even more striking. Um, so if you see in a good inspiratory CT and you say, oh, it's 31 millimeter, it's a dilated trachea, the patient has osteomalacia, is that the right thing to do? Absolutely not. You cannot make that diagnosis on definitively purely based on an inspiratory CT. You need an expiratory CT to follow that up, because you want to demonstrate that that trachea isn't performing the way it should. What you're seeing is too much collapse of it on expiratory film. The It's usually a common indication in ITU patients, and the more complex centers, if you guys work in one, you will have the occasional ITU consultant call you and say, well, I'm trying to wean the patient off. The patient has been intubated for a month or 2 months, and they're not doing as well as I think they should do. And that's a very common scenario, and more in 95% of the people, there is no finding on CT to describe it. But what they will ask for is you to do a CT on an extubated patient, or a patient who keeps coming every 6 months or every 2 years with respiratory failure, and then they stay in the ITU for 2 months and they get better and they go home, and a year later they do the same thing again. Um, so those are the two scenarios when you will get asked for a CT to look at the trachea. What they will ask for is, does the patient have dynamic airway collapse? So some people ask, is there um, a reason to do a dynamic CT, like a fluoro CT? And there isn't. That is unacceptable dose. What we do is we do an inspiratory spiral CT, and if you want to do a dedicated looking at the tracheal morphology, you can't do that without looking at the tracheal function. And the way to do that is to see what it looks like in inspiration and then see what it does in expiration. What you want to see on an expiration scan is that the trachea goes down a bit. It goes and goes down. That is normal. What you are looking as pathological is you go and then when you expire out, it completely collapses. And when it completely collapses, it doesn't go back up. And that's how the patient presents in respiratory failure. That collapse needs to be more than 50% of the diameter, the interior posterior diameter of the airways for you to start thinking down that route. If you want to be absolutely sure, you want more than a 70% reduction in that trachea. That reduction can be in the trachea. If you see it in the trachea, you will most certainly see it in the right and left bronchi as well. When you see it in the right and left bronchi, it makes you very much more confident in calling that diagnosis. It happens in the conducting airways only. That's how you demonstrate it on CT. So yeah, in summary, the absolute size doesn't matter. In If you wanted a figure, the figure is 3 for everyone. In literature, it's 25 for males and 21 for females millimeters. But that's assuming a normal sized male and an average sized female. Um, some people then ask, is a trachea too small to show tracheal stenosis? Somebody having a tracheal stenosis will have it at birth. They will be born with it. It's a pediatric diagnosis. Somebody having tracheal stenosis in adulthood will have a cause of it. That cause cannot be missed. They would have been intubated or had trauma or had inspiration with a caustic agent or something like that. So the stenosis, if somebody has had a normal life, has had no specific local trauma to the trachea, iatrogenic or otherwise, and the query is tracheal stenosis, you can go ahead and reject that CT report. So there is no diffuse size of the trachea that is too small. It is not, everybody has a normal anatomy. What tracheal stenosis means is focal stenosis. So they will always ask for focal stenosis, and it will be at the site of previous tracheostomy or previous knife injury or something like that. So no non-traumatic cause for tracheal stenosis. Okay, I've put this slide in just to talk about segmental anatomy a bit. This is something that puts off non-chest radiologists a lot. The thing to remember about segmental anatomy is it is much more important to a surgeon than it ever will be to you, unless you are a chest radiologist. The only reason over recent years it has become important is we are doing segmental resections. So not long ago, certainly in my lifetime, the only treatment for a certain lung cancer was lobectomy or even pneumonectomy. Over time, for primary and metastatic disease, there is a trend towards segmentectomy. What that means is you save more normal lung. So previously, whereas if there was a tumor here, the patient would lose all of the left lung, left upper lobe, sorry. What they would do now is isolate that segment and cut that out. That is why segmental anatomy has gotten more important in recent literature. For a general or non-chest radiologist, and certainly for a radiology registrar, knowing the segmental anatomy inside out, don't worry too much about it. If you're in an exam and the examiner doesn't happen to be a chest radiologist, their segmental anatomy will be just as bad as yours. So don't worry too much about it. Don't stress about thinking about, oh, I don't remember how many segments in the left lung or the right lung. You can easily Google it. We all every now and then have to open, Google and Radiopedia or something. So this can be one of those. If you were really interested in it, and this is it, segments, like I said, important for the surgical team and the chest radiologist for MDT discussion. What they will do sometimes is it becomes important in MDT discussions where the pathologist will say, well, I looked at the segment resection you sent me, and I think it's extending beyond the left lung. the margins, and then we will think, oh, which margins and which segment. Then the patient will come back and have the whole lobe taken out. So I wouldn't worry and focus too much about it. This is the bronchial segmental anatomy. Again, don't worry too much about it. I wouldn't spend too much time on it in this session, because I'd rather focus on the terminology. I've put this slide in just to help you understand the structure of the lung. It's important to remember that the lung is actually a sac of millions of sacs of air. The way to describe a pathology is to think about this slide right here, is where you think where in the lung is it? Is it in the airway? Is it in the distal airways? Is it beyond the airways in the air sacs? Is it now leaking outside the air sacs, as in it's so much it's oozing out? Was it never in the air sacs to begin with? It was around the air sacs, because the air sacs are not floating in a vacuum. They are surrounded by interstitium of the lung. Interstitium of the lung is just fibrous tissue and just structure holding it together. What that structure has is blood vessels, lymphatics. That's it. So that's what you have to remember. And it's very easy to think of this when you look at CT. That's the beauty of the chest CT, is when you magnify it in a good quality CT, you will be able to look at the CT image and think about this and be able to differentiate where the pathology is. And I'll come to that when I show you that. This is a bit out of sync, but I'll just put this in because this is again something that is overdiagnosed. The thymus. People think, in adults the thymus shouldn't be visible. Well, it shouldn't be. But is there an exact age cutoff beyond which you can't see a thymus? There isn't. Are there phases in our life our thymus goes into hypertrophy or hyperplasia? Yes. With COVID, even COVID has case reports or quite a bit of literature around this. The thymus goes under hyperplasia after they've recovered from COVID. There's studies going on about, will it go back? Is it pathological? Will it turn into lymphoma? Is it, should it be resected? So thymus is a normal structure that is in every chest when we're born. It's quite significant. It's a lymphoid tissue. Over time, it invulates. But due to various stresses over our life, be it pregnancy, chemotherapy, trauma, any time of shock, any stress on the body, steroids, COVID, it can go under hyperplasia as well. So that's a pediatric film. That's how broad the mediastinum is, and that's the sail-shaped sign of a normal thymus. Many children, it should be common knowledge to pediatricians, but even my own daughter in the UK was diagnosed with upper lobe pneumonia based on her thymus. And I just happened to be in that ward and could report it, but they had already given her antibiotics by the time I saw the X-ray. So it's still pretty common. Over time, you see how that changes to this. The likelihood of you seeing a thymus, hyperplastic thymus, even on an X-ray in an adult is nil, near nil. You will see it on a CT. So that's how it looks in a child. You ideally want it soft tissue or a bit fatty. Can enlarged thymus in a child be pathological? Well, technically it can be, but imaging will not differentiate it. Over time, it evolves into this fatty sort of flattened structure. And the most common scenario these days or everywhere is that it's an incidental pickup and you don't quite know what to do with it, and you watch and you see it varies from trust to trust or region to region in the UK and across the world about what you did or what you do locally with an incidental thymic lesion. This I put in for you to understand some requests that come in with patient presented with suspected phrenic nerve injury, and we forget that the phrenic, and most of us think phrenic nerve diaphragm, that's it. But if somebody presented with the phrenic suspected phrenic nerve malfunction, you have to not only think of the diaphragm, but have to think where that nerve has been before it touched the diaphragm. So that's the course of the right and the left phrenic nerve. So any pathology along this course on the right and on the left pressing on that nerve could actually give you paralysis or malfunction of this diaphragm and cause it to be elevated. That's a lateral view of the phrenic nerve.
We've lost your voice actually, and also lost your video.
Involved with near the
Excuse
patients that put, sorry.
we for a while we lost your voice as well as your video. So can you go back and repeat? I could not hear anything on the last slide.
Can you see me now?
Yeah, I can hear you well. Can you go to
Can
the
you see me
last
now?
slide? Yes, definitely yes.
Yeah.
So can you go to the last slide, the previous
Should
slide?
I go back to the phrenic nerve?
Uh, yes. Now, uh, yeah, from here onwards, can you repeat whatever you said before?
Okay. So we were talking about the phrenic nerve. And the phrenic nerve course is straightforward on both sides, on the right and the left. This is different than the left recurrent laryngeal nerve, which is the cause of all sorts of pain for a head and neck radiologist. This is the nerve that courses down and then winds around and goes back up. So along that course, any lesion pressing on that nerve can present with a vocal cord palsy. This can also be a lung tumor, it can be a vascular tumor, it can be a vascular aneurysm, anything pressing on it along that winding course back up can cause left recurrent laryngeal nerve pathology. So this is what I was talking about before, that this is the phrenic nerve. Anything along this course can press it and cause it to malfunction. For example, this tumor here is here, pressing on the phrenic nerve here, causing it to give right phrenic nerve palsy, and as a result cause the right hemidiaphragm to be much more elevated than the left. This is a case of a left recurrent laryngeal nerve palsy picked up on a head and neck CT. No cause identified on the head and neck CT, so recommended a chest CT and showed extensive pathology around this area, causing a pressure effect and involvement of the nerve and causing that palsy. Can we take a 5-minute break before we start the terminology?
Please. So 5 minute break. Can you stop sharing? Sessions for example, interstitial lung disease, and many of the questions which have been put, just wait for those sessions where they will be answered in more detail. Over to you, Samoya.
Okay, so this one is, I'm pretty sure, is pretty simple. Most of you will pick that this is ground glass that I'm showing you. And this is, I think, in case of COVID. This one is what I want you guys to tell me what this is showing, where the arrows.
So this is a 30-second slide. So I hope you, okay, so gravy, reverse, hello, crazy. Last 10 seconds, please. Over to you.
Yeah, so if you notice where the arrow is, you see that there is ground glass and you see thin lines going through that area. You can see the lines of the septal thickening more prominently elsewhere, but even in that specific spot, you see lines and ground glass. So that is indeed paving. This is actually a case of ILD, but that specific area that I'm showing you is a focal appearance of crazy paving. So well done, Farheen and Hamid. Next one is this one. If you just tell me what this part where my mouse is showing you.
So 30 seconds once again, please. Can you put the mouse again, please? Yeah. 10 seconds. Over to you.
Okay, so well done. This is consolidation because you can see these dots going all the way through it. It's positive air bronchogram. Somebody has put in OP, but if you notice, the consolidation is posterior and it's dependent. And that is not a pattern you see in OP. OP, you want to see peripheral and peribronchial. This is ground glass and this is consolidation. This is, I think, a case of ARDS. This one,
30 seconds.
and my follow-up question to this is can this be cancer?
Last 10 seconds. Over to you, please.
Yes. So that patient with that if that is consolidation and that cavity sitting in there is indeed in the lung, so this is a cavity, and that patient should be very unwell. This patient walked in to get that CT. This has to be very suspicious for cancer because you don't get that thick walled cavity, and cavitating lung cancer is not that uncommon. So this is a cavity. In an unwell patient, this would be consolidation with secondary cavitation, or in a reasonably well ambulatory patient, it would be suspicious for cancer. This one, just tell me describe it to me. Some of the terms you would use in this one. It could be consolidation. Use more than one.
So now we begin with 30 seconds. Last 10 seconds. Over to you, please.
Yeah, so this slide shows quite a few terminology signs you could use. Ground glass, yes. Mosaic, yes, because mosaic is essentially meaning just that there is a difference in attenuation. A bit of ground glass, a bit of dark. I can't tell whether the dark is too dark or the ground glass is too white, but the lung is heterogeneous. So yes, there is a mosaic attenuation. But what is important about this ground glass? It is nodular. There is a texture to it. It's like if you touched it, you could have a texture in your hand. And that means that it is nodular looking ground glass. And when there is texture to ground glass, that nodule is almost always in the central lobular distribution. So you have central lobular nodularity on the left, you have mosaicism, you have ground glass. So those terminologies you put on a piece of paper. Yes, exactly. So you have hypersensitivity pneumonitis. Very good. Hola Jahan Sep. And I think this is the last one. No.
So your question, please. What do they want? What do you want?
I would like to tell me what this distribution is.
So we begin
And
now.
this is just to confuse you. Remember that.
Last 10 seconds. Over to you, please.
Okay, very good. It's very good. Almost none of you got confused. This is indeed all diffuse ground glass with a few lines in it that you can't explain away as vessels. So this is superimposed septal thickening onto a ground glass. And that is, yes, it could be pulmonary edema, but this specifically histologically is alveolar peritonitis. But that's, yes, I agree. That's a very good differential. Pulmonary edema definitely would be in there if this patient was an acutely unwell patient. And because alveolar proteinosis is known to have a patient that looks like me and you, they would be completely normal, walk in and have a horrible looking CT. If this patient was unwell though, pulmonary edema doesn't look this pretty. What you do get is dependent consolidation, a bit of fluid, the heart is too big. It's a messier looking picture in pulmonary edema. I Okay, this sign should be straightforward.
So 20 seconds, please. The slide, I believe, has shifted. Can you
Yes.
work?
Yeah. Sorry.
And
Yeah. But
yes,
everybody's right. This is
yeah, I mean,
reverse
over to you,
halo, very
please.
straightforward.
Yeah.
Reverse halo sign. Indeed, it's ground glass in the center, surrounded by dense consolidation level, soft tissue level looking intensity around it. So that's a reverse halo sign, positive in this patient. Um, this one is just to show you, for the purpose of time, is to show you this. There are two things I'm showing you, both to do with that arrow. So there is bronchiectasis. Yes, exactly, Dr. Mahesh. Perfect. So that's bronchiectasis, and there is bronchial wall thickening. Bronchiectasis just means dilatation. When the wall is thickened, you also have to mention that because that means chronic inflammation and possibly superadded infection. So there is bronchiectasis and bronchial wall thickening. This is the last one, and this was just for teaching purpose. This wasn't a viva. This was to show that there is a difference between mosaic attenuation and normal appearance. Mosaic attenuation is this, which you all perfectly picked on the earlier slide. This is what normal lung looks like over age. And just to understand it, as we grow older, our lung is also tissue that gets less compliant. So over age, and there becomes this density. The top half of the lung is more loosened, the bottom gets a slightly higher density, and you get these focal areas of low attenuation. That's a very known, literature proven appearance of a normal old lung. I think that's my last slide. Some of the references you can go through. Just to reiterate, that website was Radiology Key if you wanted to go through the terminology again. And that's about it from me.
Okay. So thank you very much.